My talk is on value-based payments, and I wanted to kind of turn this into a question, I think, and maybe a real-life question. And the real-life question is, should I accept one of these things, these opportunities that might come along? And I kind of framed it this way, and this is maybe some considerations that you can kind of keep in your back pocket as we're going through this. So if I'm offered a value-based payment contract, should I sign this thing? And here's an important corollary. If the value-based payment system is forced upon me, what should I have done to prepare for it? Now, it may be that many of you on this call don't read the Journal of American Medical Association, or JAMA, but just 3 weeks ago or so, Don Berwick and the prior director of CMMI wrote a viewpoint piece suggesting the future for the Center for Medicare and Medicaid Innovation, or CMMI. And they suggested that ACOs be mandatory across the country. Mandatory. Right now, they are voluntary. And I'll talk about ACOs in this. But as we think about if value-based payment system is forced upon me, two very influential people in healthcare policy just recommended that it be mandatory. So with that, let's kind of get started, and we can talk a little bit about value-based payment and value-based care. I want to start first with a concept I hope you all are very familiar with, and that is the importance of the healthcare system to lead us towards 3 different aims or goals. And that's better patient care. And when I say better patient care, I mean better quality, better patient safety, and a better patient experience. Improved community health, and of course, smarter spending of our hard-earned dollars. Now, this actually came from Don Berwick when he was at the Institute for Healthcare Improvement. He also had a short stint at CMS, and you all may not know this. So Don Berwick is if not the leading quality improvement expert in the world, he should be. He's actually knighted by the Queen of England for his work in quality improvement. So he coined this word called the triple aim, and he also brought it to CMS when his short stint there. Now, shortly, about 2 years or so before Don Berwick published this concept of the triple aim, and he published it coincidentally in JAMA and elsewhere, I came up with this pretty simple mathematical equation in 2006 for a talk I was giving in the UP of Michigan. And I was giving a talk about why it felt like healthcare reform was being forced upon us. This was not too long after the Medicare Modernization Act. And I think a lot of hospitals and clinicians were feeling kind of pressured that they were getting hammered by healthcare reform. And I postulated at that time that the reason why healthcare reform is being kind of forced upon us is because we're not giving the healthcare value, we're not providing the healthcare value that we know we're all more capable of. And I kind of said, well, let's think about value in a simplistic way. And I kind of talked about it as clinical quality plus the patient experience divided by cost. So I'm not a mathematician, but I can add and divide. And this kind of felt to me a way to convey what we weren't delivering as well as all of us knew we could. But we've got a problem, right? So some of you may know the problem. The problem is we're not paid for value. We're not paid for value. We're paid for something else. So along comes Winston Churchill. And if Winston Churchill didn't say this, he sure should have. And he said, again, we don't know if he said it, but anyway, it doesn't matter. You can always count on Americans to do the right thing after they've tried everything else. So let me tell you about the tried everything else. And I'm going to try to put it together from a patient perspective. Fee for service. What fee for service is my doctor gets paid more the more he or she does to me, whether it helps, hurts, or does nothing for me. Now, does that make sense? No. Okay, let's try something else, completely else. Let's try capitation. My doctor gets paid exactly the same amount, no matter how hard he works or she works for my good health. Does that make sense? No. So we might say, well, let's just let the market take care of this. Well, the market right now in the United States is driving a $3.5 trillion industry. It's like the 4th largest country in the world or something like that. And the dollar bills of $3.5 trillion bills like go to the moon back and forth several times. Nobody can actually calculate. So I'm not sure the market is actually working all that well in the American healthcare system. And I'd also argue it's especially not working well in rural areas. Some people are arguing for a single payer system. Well, I think a single payer system may add some efficiencies to our industry, but it really doesn't get at value. So I kept asking, what about paying for healthcare value? So before I go a little bit further, I want to pause and kind of talk a little bit about this idea of value. It's much more nuanced than the AAA makes it seem. It's much more than a quick equation that Clint just thought up quite a few years ago. You might even ask, what is value? Is it a noun or is it a verb? And what's particularly important in this concept of value is what perspective you come from. Are you a patient? Are you a taxpayer? Are you an employer? Are you a hospital CEO? Are you a clinic manager? Are you a physician? Are you a nurse? All of those perspectives are valid, and all of them will define value differently. And even if we just for a moment assume that value has those 3 components of better patient care, of improved community health, and smarter spending, how do we prioritize those? Are they all equal, or is one more important than the other? But the challenge, I think, here is that we might let perfect be the enemy of good. In the previous slide, I kind of told you what we've tried until we do the right thing. Well, we've tried a lot of things. I don't think it's working very well. So even though I'm probably not here to espouse an opinion, I really think that this volume to value transition, this idea of getting paid on widgets or fee for service to where we get paid on value, this transition, it's called the volume to value transition. I think that should continue. Now, let me talk about payment for just a second. Now, you may say, well, why is this physician talking about payment, for crying out loud? Well, it's not because I believe that money is the only thing that makes the world go round. I also don't think that it's money is the thing that allow hospital CEOs to command and control their organizations and their market. But I think of financing or payment in a little different way. Payment for healthcare services allow each of us, whether we be clinicians or whether we be administrators or healthcare leaders, to deliver on the services that are essential to our community's health and vitality. That's what's important about payment. And also, in this particular case, if you want to receive value-based payment, you need to deliver value-based care. So anyway, that's why it's important for us to start learning about these concepts. Now, payment, this value-based payment, is not a payment for a service. It's not a fee for service. It's not for a widget production. We've got, something about 8,500 or more individual services that we provide in healthcare. That's all the CPT codes. And most of them actually have a value, a monetary value assigned to them. That's like kind of producing washing machines or something like that. So paying for value is not fee for service. Now, even though I've kind of talked about the importance of value-based care a bit here, our historic emphasis in the United States has really been about cost reduction. We used to kind of joke that in the previous administration, the triple aim was cost reduction, cost reduction, cost reduction. And then it was kind of hoped that better patient care and improved community health will kind of come along for the ride. I think this new administration will be a little bit different than that, but I don't think that this emphasis on cost reduction is going to change. We're paying over twice as much per capita for healthcare in this country as almost anywhere else in the world. So, and also without the quality that's expected. So I think that the new administration will not change that focus too much, but we'll certainly, we will see. Now, I want to talk a little bit about form following finance and this important concept. How we deliver care depends on how we're paid for care. Now, this doesn't mean that all doctors, nurses, and hospital leaders and clinic managers are all charlatans and all they do is think about making money. But at the same time, when all of your financial motivations are taking you in a certain direction, it's challenging to be able to shift to what you think might be more right. And even though, and that right may actually jeopardize the financial integrity of your organization. So it's important for a critical access hospital to fill its beds. We used to joke that financial managers in clinics and hospitals love flu pandemics. And if nobody stayed home for their COVID infections, we probably like COVID pandemics too. Now, you all know I'm being tongue-in-cheek here. But the truth of the matter is volume drives the financial success of an organization. But healthcare payment reform is trying to change that. And what it's doing, it's actually transferring financial risk from the payers, that'd be like the insurance companies, Medicare, Medicaid, to the providers, which would be like hospitals and doctors and clinics and nurses. Now, when that starts to change, when this healthcare reform starts to come about, what we need to do is we need to start getting very good at cost benefit analyses or risk assessment. And remember, when I'm talking about risk, I'm not simply talking about bad things. We tend to think of risk as something bad, but actually risk can be risk for something good or risk for something bad, cost benefit. So even though I tend to kind of fall into risk as being bad, please keep in mind that risk is simply a likelihood of change. It's not necessarily good or bad, but we tend to talk about it that way. So I want to introduce you to a financial risk continuum in this next slide. So if we think of this continuum from on the left side and on your screen of high payer risk, and on the right side, high provider risk, that'd be hospital, clinics, doctors, et cetera. We could start on the left with fee for service. Now, the reason why this is high payer risk is, newsflash, doctors and hospitals can increase their services. They can increase volumes. We like to think as doctors, we like to think, no, this is all the patient's choice. Well, actually, it's not so much. Actually, I just read a study not too long ago, actually the past few weeks, I think that looked at where patients went for care based on cost or their physician's recommendation. And even when the out-of-pocket costs for an MRI scan or a CAT scan or a colonoscopy happen to be higher at one facility versus the other, the patients would often choose the higher out-of-pocket cost place if their doctor recommended it. So we tend to have more control over these things than we think we do. And over at the other end of the scale is the high provider risk, where if we are as a hospital system that includes clinics and doctors and nurse practitioners and physician assistants, as a hospital system, we're actually on the hook for the cost of a community's healthcare. That's high provider risk, Now, as I said, this is a continuum from pay for performance and value-based purchasing, shared savings, bundle payments, global budget. I'm going to talk about two here to just give you a sense of kind of examples of this financial risk continuum. So what is an ACO or an accountable care organization? You've heard these words a lot, ACO. Some of you on this call may be participating in an ACO, so you can teach us all too if I'm wrong about this. But an ACO is a group of providers, generally physicians or hospitals, generally, that receive financial rewards to maintain or improve quality of care for a group of patients while reducing the cost of care for those patients. So you've got two priorities. We got to maintain or improve quality, and we got to reduce costs. That's what an ACO does. It's a new organization that does that. And this happens to be CMS's largest value-based payment program. Get this, look at this. There's over 1,000 of these organizations operating in the country right now with over 33 million patients. 33 million. That's 10% of the entire country is operating in one of the, is cared for in one of these ACOs. There's 477 Medicare ACOs, and nearly 30% of Medicare fee-for-service beneficiaries are currently served by an ACO. And you know, these things just got started in like 2012. They're not that old. So all of this is happening kind of primarily led by Medicare and the Center for Medicare and Medicaid Innovation, but now followed along by Blue Cross Blue Shield and Aetna and United. Many of the larger commercial insurance companies also have ACO or ACO-like organizations. So here's accountable. This is what's happening on this map that you see, what's happening in rural areas. Lest you think that this accountable care organizations are only happening in the big cities, think again. These are counties, and we have colored only the rural counties in which ACOs are operating. And gosh, look at the dark ones where 3 or more ACOs are actually operating. As I mentioned before, an accountable care organization is held accountable to both cost savings and quality performance. And then if there are cost savings, CMS, in this case, Medicare ACOs, shares the savings with that ACO. Hence, it's called a shared savings program. Now, here's a couple of important caveats about this program, especially for those of you who are from the hospital world. I mentioned up above in the first bullet, cost savings and quality performance are required. Well, then you might ask, well, where are we measuring quality? We're not measuring it in the hospital in these ACOs. We're measuring it in the primary care offices. That's where quality is being measured. And how do you get in? If you're a patient, how do you get into one of these ACOs? You get in through your primary care provider. In general, general internist, pediatrician, family physician, nurse practitioner, physician assistant, generally. So what that tells our hospital colleagues that we really need to work closely with our primary care practices to be successful in ACOs. Now you might ask again, so how do the finances work for these ACOs? Well, I have a hypothetical Medicare ACO patient to show you. Let's just say in our hypothetical Medicare patient, he or she is predicted by Medicare to spend $10,000 of Medicare dollars over the next year. Now, when I say Medicare dollars, I'm talking about everywhere. I'm talking about hospital, clinic, both Part A and Part B, not Part D in this case, but Part A and Part B, no matter where that patient receives the care. So those of us from Wisconsin and Minnesota, and we see a whole bunch of our patients go down to Fort Myers over the winter, that particular spending is being counted down there in Fort Myers, Florida, as well as it is in rural Wisconsin or rural Minnesota. But let's say your patient has joined your ACO, and you know what? You're identifying that they're coming to the emergency room more often than is necessary. And if we set up good primary care visits, we can decrease their ER visits. We find out that they're being readmitted to the hospital for things that we really should have prevented, or we should have taken care of it in home health. And we apply care coordination. We apply good patient management that I will argue is better for the patient. But we end up actually costing Medicare $1,000 less when we start applying our expertise to managing these patients in the right way. So now, in this next year, Medicare has only spent $9,000 on this patient. So we've got $1,000 left over. We just saved $1,000 for Medicare and the taxpayers. And remember, I said, if we save money for Medicare and the taxpayers, Medicare shares part of that money with us. So 50% goes back to the accountable. Medicare writes a check for 50% for this particular patient, multiplied by how many ever patients that you have. And you get a check for $500. And you might say, wait a minute, Clint, what happened to the other $500? Well, the house always wins. Medicare keeps that. And we're not done yet. I sound like a Popeil fisherman ad. We have that quality adjustment. So if we didn't provide the expected quality for our patients, part of our money may be deducted. So in this particular example, the accountable care organization gets actually only $450. Now, please understand that this is kind of a what I'm calling here a one-sided risk model. So this is where simply if there's a excess, or if we save Medicare money, they share it with us. You might ask, or inquiring minds will want to know, what happens if over here it's actually $11,000? Yikes. What happens if we spend more on our patient than we anticipated? Well, for most ACOs right now in 2020, 2021, we don't have to pay that money back. But increasingly, if this is above our predicted $10,000, we'll have to pay part of that back. So that's called downsided risk, upsided and downsided risk, and that's increasingly occurring. One other thing I want to point out about this particular model is all through the time that we move between the predicted time to the actual time, we're still getting our fee-for-service income. We still get payments for our ER visits, our clinic visits, for our hospitalizations, for our MRIs and our CAT scans. We still get paid for all those. But so what that means is this is still fee-for-service in essence. It's simply shared savings if there's any savings in it. So, and I won't go into the accounting details of why this is, but it's extremely important in this particular model that you keep these patients in-house as much as possible. It's much more financially beneficial for you to care for these patients within your ACO rather than having them go down to Fort Myers, Florida for their care. And we can talk about that if anybody has more questions about that in a second. So what's the benefits of this ACO? Well, first of all, it's a toe in the water. It's relatively low risk, financial risk way to learn about value-based care and value-based payment. And the other really cool thing about the ACOs, and I don't know so much about the commercial ones because there's so many, but in Medicare, you get all the data. You know exactly where your patients are going to get their care. And when you identify that they're going to the neighbor town for their care, you can help to understand why that is and hopefully bring them back with better care and better service. As I said, it's still a fee-for-service platform. It's volume driven, but the goal here, kind of the managerial goal, is to shift the care to less expensive providers, including your own. That's the goal. Now, what are the risks? Well, there is some upfront investment. One of the things we need to do, value-based care requires financial risk management, population health management, data analytic capacity. So it requires at least some upfront investment. Now you can buy those services. Caravan, for example, is a consolidator of ACOs that provides those services. Adelaide is a organization that works with primary care practices exclusively to help them become effective ACOs. But I call this R&D. In healthcare, we never really talk about research and development, do we? But we really should. So if there's money in your organization to invest in research and development, this is a place to do it. It's a place to do it. I already mentioned downside shared risk. That is becoming increasingly prevalent. And at the very bottom, I want to emphasize again that primary care engagement is critical for success. So, and I'll talk about that a little bit more later on. Now, what about a global budget? So this is brand new. I'm working very closely with the Pennsylvania Rural Health Model, which is paying hospitals global budget. But in a hospital global budget, what happens here is a fixed amount of money is paid to the hospital per time period. Think of it almost as the hospital gets a bag of money on January 1st and now is told to take care of their patients for the next year. That's what it, now it's more complicated than that, but that's the idea. The key here is, and this is different than in ACOs, the amount does not vary by the number of services provided. So what's our goal? Our goal here is health maintenance. All of a sudden, flu vaccine clinics, COVID vaccine clinics become really, really financially beneficial for us. We are focusing on health maintenance rather than simply illness treatment. How many times have we heard the phrase, we have a sick system, not a health system, a sick care system, not a healthcare system? Well, it's true. It's true. We are paid to take care of sick people with some exceptions. You know, we get some preventive health, but primarily we are paid to take care of sick people. This flips that particular focus on its head. And isn't that refreshing? Isn't that refreshing that we might be able to start thinking about how we will be financially whole if we keep our community healthy? Here are the current models from Center for Medicare and Medicaid Innovation in the country, the Maryland Total Cost of Care model. Maryland's been at this for about a decade, only state that has. They just recently started including physicians in the model. The Pennsylvania Rural Health model is going on 4 years, in its 4th year now. I'm very involved with them. No physicians involved, no practices involved, only hospitals, which is a problem. And then we have upcoming the Community Health Access and Rural Transformation, or CHART model. And that's pending, that we hope will start sometime next year. So this hospital global budget is not as prevalent as ACOs, but it's something to really keep an eye on. Now, why would you want to keep an eye on this? Well, I'm still using hospitals as my example here, but I think it would probably work for clinics as well too. If you're seeing a hospital revenue trend line that looks like this in your organization, and you don't think that there's any way that that is going to change because your population is declining, or because a competing community has been particularly successful, for whatever reason, if your revenue, your income from patient care is looking like this from 2019 going forward, and you're honest about it. I've hardly met a hospital CEO that doesn't think he or she, through the magic of his wisdom and expertise, is going to be to change the trend. But in reality, that doesn't happen. And in fact, we've seen 120 plus hospitals over the past several years close. And even though the reasons for closing are multiple, this is generally the reason right here. But what a global budget does, it comes in up my line here at 2022 and offers you the same fixed amount. And look at the difference in 2024 between where the projection is and where your revenue is. This is obviously a good idea for many hospitals. I had one hospital CEO say, it gives me financial breathing room. I think that's probably appropriate. So, and this particular model is appropriate if your organization has a downward revenue trend, there's a declining population, or you're financially distressed and you don't think realistically, honestly, that you're going to be able to get out of that financial distress. It gives you breathing room, a lifeline. It's probably not appropriate for organizations with upward revenue trend. And again, I ask you to be honest about it as well too. And also, I might say, being honest about what happens in your current status quo. Now, what are the risks? The risks here. Well, if you get a global budget and your volume goes up and your costs associated with that volume goes up, well, that's a problem under a global budget. But I can tell you in Pennsylvania, the rural hospitals that saw their volumes just tank during COVID were very thankful for the Pennsylvania Rural Health Model because their revenue stayed the same through this. So the global budget does lock in historic revenue, but still reducing costs is difficult and future budget adjustments are unknown. Unless you think you can kind of help your business department find other work, you still have to code claims for risk adjustment and co-pays and quality assessments. So you still got your kind of claims and billing departments in your clinics or your hospitals. And I want to end this particular slide with something that's very, very important. That many hospitals, less so clinics, but many hospitals are already at financial risk, The status quo is often not risk-free. And please keep that in mind. People tend to think that if I do something new, it's going to be risky, but staying the same can be risky as well too. So let's come back now to my first two considerations. If I'm offered a value-based payment contract, should I sign it? And my corollary, if a value-based payment system is forced upon me, what should I have done to prepare for it? Well, this is where you start. And I know that at least right now, you don't have active links on your screen from my PowerPoint presentation, but Kiona will help to make sure that these links are active in what she posts, so you can click on this and the next four resources that I'm going to offer you about value-based payment and value-based care. So first is kind of take a look at this value-based care assessment tool. It is about a 2-hour process that you do with your leadership team to assess your capacity for value-based care. What's really cool about it, though, is it points out opportunities for you to build your capacity. It's not a way to test yourself or compare your skill as a CEO. It's nothing like that. It's to identify opportunities to build your capacity to deliver value-based care and, importantly, to receive value-based payment. Next, I have 5 individual tasks, and we will go through each one of these. So first, we need to understand this concept of risk. And remember, I mentioned risk doesn't necessarily mean good or bad. It's upside and downside. We also need to understand a particularly irrational human bias called loss aversion. We just don't like doing things that might cause a loss, even though statistically they will offer improvement. Let me give you an example of loss aversion. I'm flipping a coin. And what I ask you is please give me $5. And if we get heads, I'm going to keep your $5. But if it's tails, I'm going to give you your $5 back and give you $10 in addition. Are you going to take my bet? You should, because statistically you win $2.50 each time. Statistically you do. That's loss aversion. A lot of us wouldn't take that bet, but we really should. I won't go into accounting details again, but again, it's important when we start thinking about financial risk to understand what are fixed and variable cost ratios. Again, we could talk about that at a different time if you wanted to, but this is pretty important in your ability to make a profit in value-based payment. We need to have very good pro formas. My belief is that hospitals and healthcare organizations should have a 5-year financial projection, if not a 10-year financial projection. And sensitivity analyses, what those are, is that allows you to change the inputs into your projections to see how changes in volume or changes in prices or changes in costs might affect your profitability later on. And it requires an informed and honest and candid assessment of the finances, of your environment and the future. And I got a cool resource for you there. Some of you probably know Eric Schell, a buddy of mine from Stroudwater that I worked with for 8 years. He and I, probably mostly Eric, developed an Excel spreadsheet for critical access hospitals to understand their financial future under cost-based reimbursement. And again, people think cost-based reimbursement is going to be the lifesaver of critical access hospitals around the country. I've got about 120 or 130 examples, well, not all CAHs, where that's not always the case. So this is a pretty cool Excel spreadsheet to help you assess financial projections in critical access hospitals. Next, and I can't emphasize this enough, is engaging physicians. And let me pause for just a moment. I'm using physicians here because the literature around this work is primarily done with physicians, but I really mean clinicians. So this can and should include physician assistants, nurse practitioners, even non-nurse practitioner nurses, that we start thinking about how do we engage clinicians in our organization. So let me read this. Physician engagement is proactive physician involvement and meaningful physician influence that lead the organization toward a shared vision and a successful future. This is really important. And you know, let me give you an example. Terry Hill told me about this. He was at a meeting of accountable care organization medical directors. There was like maybe 100 medical directors in the room. And he or someone else asked, how many of you were involved in the earliest days of the accountable care organization formation? And the answer was 15 or 16 out of the 100. That's awful. That's awful. And I can tell you, as a physician, one thing physicians really hate, and you know, and those physicians, they're like elephants. They just don't forget. And if you ask for a physician's opinion after the decision has been made, they will sniff that out right away. So we want to proactively involve physicians, and we want meaningful influence in the organization. And that doesn't mean they're the final deciders. If you're in a hospital that's governed by a board of directors, physicians don't have the final say, but that doesn't mean they shouldn't have input. You know, and this is a cultural phenomenon. We'll talk about that in a sec. And really what it involves is trust. And at first I wondered if you could actually measure trust, but it turns out that you can. And people smarter than me, like Gallup and HealthStream, actually can assess trust in your organization. So I've got another resource for you. This is something that I wrote called Physician Engagement, a primer for healthcare leaders. That's available through our Rural Health Value website. And again, Kiona will make sure that we have that link active for you. Next is expand this concept of community care coordination. This is more than just discharge planning or, heaven forbid, utilization review. I can't stand that word. This is more than that. This is helping ensure that your patients receive the right care at the right time, at the right place, and with no duplication. I underscore the word community-based here, not just care coordination, community care coordination, because we have to involve our community-based organization. This really does take a village. We cannot do this alone. We can't do this just as a practice, although FQHCs, patient-centered medical homes, and we're changing the wording on that. I'll get to that in a second. Patient-centered medical homes are getting there, but we really must engage area agencies on aging, social services, transportation options, Meals on Wheels, tech, even education systems and law enforcement. We need to be engaged in our community to make sure that our patients receive the right care, the right time, right place without duplication. Now, I'm a big fan of patient-centered medical homes. This was born out of the pediatrics discipline 50 years ago, but we're starting to change the wording a little bit, but people don't know the wording yet. First, I'm switching to person-centered. I want to engage people that are not yet my patients. And secondly, we're starting to change the word medical to health home, to underscore that this is more than just medicine, it's health. This does require data analytics, and I got a great resource for you if you want to expand on your current care coordination program or you're just beginning. And this was developed by Stratus Health, the quality improvement organization in Minnesota. And they developed a community-based care coordination, a comprehensive development toolkit. And I got to underscore comprehensive. This is a great resource for your organizations that have hired a care coordinator, and he or she wants to get a comprehensive care coordination program going, not just for your organization, but for your community. Next, I want to talk about embracing interdependence. I wish this weren't the case, but smaller organizations with fewer resources turns out to be a barrier to participation in value-based care and value-based payment. We really do in healthcare need economies of scale. We need analytic and managerial infrastructure that those of us in the smallest organizations don't have. I work with a hospital in Pennsylvania in which the CEO is also the CFO. I worked with a hospital in the South where the CEO of an entire hospital did not have an administrative assistant. So the very size of rural does put us at a disadvantage. I won't even talk about how it puts us at a disadvantage to participate in models like CMMI, but nonetheless, we need to start thinking about how we can become interdependent. Now, when I start talking about that word interdependence, it does not necessarily mean M&A or the shorthand for mergers and acquisitions. I tend to use the word affiliations simply because it doesn't imply any particular level of relationship. It can be a handshake or it can be binding contracts. But we need to be working with one another, both within the community and with different provider organizations to develop interdependence. And I have a resource for you called Enlightened Interdependence, written by a friend and colleague of mine, Joe Lupica. And please take a look at that if you have questions about the need to be interdependent. And lastly, I'll talk about something that I think a lot of us feel is ethereal and ghost-like, and you can't get your hands around, and that's culture. When we start moving into value-based care supported by value-based payment, especially when we're moving towards global budgets, we are moving from a volume-based world to a value-based world, a fee-for-service world to a global budget world. And what's so exciting for me as a physician, it starts shifting our focus from sickness to health. Now, I'm not being naive. We will always be in the business of treating illness. We will always be. But couldn't we shift a bit of that focus to keeping our communities healthy? And we have to do that through cultural change in our organization. And this is the way you do that. It's first, we need to understand that what we do becomes what we believe. What we do becomes what we believe. Other people have said that culture is what we do when no one's looking. So culture is what our belief systems, but it starts with personal behavior, especially on the part of leaders. This is walking the talk. We start talking about value in healthcare, not simply volume. It depends on governance behavior. And governance, what does a governing board look at in their balanced scorecard? What does the governing board look at in their board meetings? Are they really interested in average daily census? Are they interested in the number of discharges? Are they interested in the amount of money we make per admission? Those are all volume-driven measures. So how do we start talking about health? How do we start talking about those services that were avoided? There's ways to do that. So how do we start doing that in our governance? And then organizational behavior. And what I mean by this is, what does your org chart look like? It seemed to me when I started in the quality improvement business, the quality improvement director was a part-time retired nurse who had an office in the closet in the basement right next to the morgue. Well, so how are we emphasizing quality improvement on organization with that kind of organizational behavior? So how does our org charts look? How does our job performance measures look? How does our hiring, our job descriptions look? These are all organizational behaviors. I've always kind of said, if you give me the org chart and a typical job description and typical performance rating for employees, I can tell you a lot about the culture of the organization. So I've been recommending this volume to value transition. That's what we've been talking about here. And I got to admit, I kind of find it exciting. I do. I think this is what most of us would want if we're patients or our family members are patients. Admittedly, it's a managerial challenge, but I think it's an exciting challenge. It starts to align incentives. And you know what's most important here? It's best for what matters. And this is what matters. It matters that our kids are growing up well-educated and happy and able to recreate safely. It means that we've got productive workers who are happy to go to work, not happy to get out of work. And it's really important that our seniors can retire with safety and security in our rural communities. That's what's important. Here's some other resources for you as well. And all these are fabulous organizations. I'm particularly involved in the top two, but also I'm being sponsored today by the third one. So thank you to the National Rural Health Resource Center, and thank to all of you on this call for learning with me a bit about value-based care and value-based payment. We've got just shy of 10 minutes, so maybe we got 5 or 6 minutes, and I'd be happy to try some questions. If Kiona, you'd probably facilitate those for me.
Absolutely. And as we enter into this Q&A mode here, I'm going to post our final evaluation, or we have one polling question that I want to ask, and then we have one more. But Dr. McKinney, can you please say more about the quality being measured in outpatient care for ACOs, and what are the measures?
Oh gosh, I can't quote the measures for you. The last time I looked, there were 31 of them, but they are measures that would be things like, so please don't quote me on these, okay? Don't quote me. These might be the percent of diabetic patients with a hemoglobin A1C less than 8. That may be. That doesn't have anything to do with hospital care. That has to do with primary care clinician care. So it's how many of your cardiac or your acute coronary artery syndrome patients, ACS patients, are on statins. That doesn't have anything to do with hospitals. It has to do with care provided in a clinic. And all 30 plus of those measures are like that. So it's not hospital-based care.
On the website, there will be the playback available, as well as a download of the slides in a PDF format, and the links will be live. So you'll be able to access the resources that were shared in today's presentation.
And if you have further questions, my email address is on there, and you can email Kiona and she can get in touch with me. I'm always happy to talk about this subject, obviously.
Thank you for attending today's webinar. And thank you, Dr. McKinney, for the presentation today. We were honored to have you as our guest.
You're very welcome. Thank you all very much.
Thank you.
Thank you.